Good morning, everyone. Thank you for joining us for our webinar today, In Difficult Times, Supporting the Front Lines. This is our webinar on disaster chaplaincy. One thing we have sort of been repeating, or at least I've been repeating, is that we are in such uncharted territory with all of this, but we do have at least a little bit of an analog with disaster chaplaincy in dealing with spiritual care and healthcare in other ways that are analogous to what is happening now. So it's not an exact match, but we're doing the best we can. And so we're very happy to have two experts here with us this morning to guide us a little bit more on what's going on and what chaplains have to offer. So let me introduce our panelists. First is Dr. Craig Katz, Craig Katz, clinical professor in the Departments of Psychiatry, Medical Education, and Health System Design and Global Health at the Icahn School of Medicine at Mount Sinai in New York. And so he's, of course, seeing a lot of this firsthand. And then we're also joined by Tim Serbin, who is Regional Director and Health Officer at I think I wrote this down wrong. You're the regional director at something in Oregon, and I hope that you can correct me, as well as the System Disaster Spiritual Response Leader for Providence St. Joseph Health. So thank you both for joining us. Craig, I will turn it to you, and then we'll get to Tim, and then we'll have Q&A afterwards, a very typical webinar format here. So let's go ahead and get started.
Thank you, Michael, and hello, everybody. So I will, I guess, maybe speak for about 10, 15 minutes. If I'm going too long, you'll let me know. Just give you kind of a broad overview of what I'm going to speak about. I'm just going to talk very broadly about disasters and mental health. I'm a psychiatrist. A little bit about how that relates to infectious outbreaks, and then talk broadly about ways to intervene, generally speaking, and then have some specific comments about health professionals and I think the issues that are likely to come up with working with health professionals, since they are my fellow colleagues are very much the sort of the front line right now that I think we're focused on today. So broadly, thinking about disasters and mental health, really we look at this in sort of two different phases. First is sort of the immediate impact or acute period, which is usually days or weeks, and then the long term, the post-acute, which is months to years. In our own 9/11 program, we're still treating people who are 9/11 infected. Nearly, well, it's about 19 years later. So the timing can vary, and the pandemic makes it a little harder to kind of figure out the timing, because it is an ongoing event, and it didn't just happen and stop. It's just rolling and rolling, so it makes it much harder to kind of predict these responses. But broadly speaking, early after a trauma, we think about distress responses, many of which can be perfectly adaptive and normal, but we think of them in terms of changes in how people feel, of course, changes in how people think, changes in changes in people's behavior. And also, some people just get physical symptoms from distress. Not everybody, as we say, psychologizes their distress, but actually feels it in their bodies. Changes in how people feel, of course, can run the gamut. Mostly, if we think about the pandemic, the predominant emotion that we think about is fear or anxiety. Related emotion, if we can call it emotion, is grief, but certainly sadness. But some people also have positive emotions from helping or being helped, and also from the sense of togetherness that an event like this can engender. Changes in thinking, of course, can run the gamut as well, from some feeling very demoralized to, at the worst, thinking about suicide. Although I have to say, suicide is a rather rare phenomenon. Most people that have studied suicide after disasters have not found that there's a change. People, every time a disaster occurs, people start worrying about suicidality. I've yet to see that be the big issue. I think a lot of people ask existential questions, which is maybe where you all can come in, about the meaning of life and the purpose, but not necessarily suicidality. And I hope this time doesn't change that. Even more broadly speaking, we thinking about anxiety or stress in particular, we think about something called the Yerkes-Dodson curve, which some of you may be familiar with from intro to psychology courses, but I think it's one of the most useful concepts in all of mental health. And it's basically a curve, and I should have brought along a slide, but you can search for Yerkes-Dodson, Y-E-R-K-E-S, Dodson, D-O-D-S-O-N, and what you'll find is it looks like a bell curve, and on the x-axis is stress or anxiety, and on the y-axis is function. And right as anxiety goes up, our function goes up. Right, we need stress actually can inspire us to action and actually enhance, not just inspire us, but enhance our ability to function and function well under tough circumstances. But then it peaks, and then it starts going down, and theoretically it can go down below zero, and you get dysfunctional, right? So what we want people to do is stay with the good stress, not the bad stress, and ideally hit that kind of the peak in the middle where people are at their optimal functioning. Of course, we know that life doesn't quite work like that. And that's all kind of in the short term. In the long term, we look at three major psychiatric problems when we're thinking about the psychiatrically that occur. One, of course, is post-traumatic stress disorder, PTSD. Another is major depression. And the third is alcohol use problems. Those are usually the big three after disasters or traumas. Alcohol use problems usually are not new. Usually what we're talking about is a recurrence of old problems, sort of falling off the wagon, not causing new problems usually. And I won't go into the details of PTSD and major depression, right? But PTSD is basically what we call a fight or flight reaction that lasts too long, outlives whatever initial hyper awareness and anxiety was functional. It lasts too long, it spills into your sleep, it makes you hyper aware in times you don't need to be, etc. And right, major depression or the syndrome, it's not just depressed mood, but a number of the symptoms, including potentially physical symptoms like sleep and appetite disturbance. And then the other category to think about psychologically with disasters and mental health is actually a positive category, and that's the categories of resilience and post-traumatic growth. Right? Resilience, it can be a talk unto itself, but when we talk about resilience, we're talking about different attributes that people have or behaviors that they can employ that help them to either, if you think about resilience, the person like a tree, right, does in a storm like a pandemic, right? Do they keep standing perfectly straight? Do they bend but don't break? Or if they bend and break, do they bounce back and they're like better than ever, right? That's kind of the metaphor for resilience. And one of the key elements actually of resilience is thought to be spirituality in its various forms. If people are fortunate enough to have a spiritual bent or a religious connection to begin with, that is an enormous source of resilience, certainly something that I see a lot actually in working in human rights and working with migrants from Central America. Spirituality is one of the biggest things that I think help them to get through and do what they do. And the post-traumatic growth actually is the idea that one can, right, hopefully grow from a trauma, right? So what does not kill me makes me stronger, right, is very much the truth. I mean, when you study it, it happens. And so we hope to promote those things. So that's broadly on disasters and mental health. To think specifically about infectious outbreaks, we have information that goes back all the way to the Black Plagues in the 1300s, and information as recently as publications that have come out of China on COVID-19 already on mental health. And just the broad description of all that, human behavior way back in the 1300s in response to the Black Plague, which was the bubonic plague, that at the time was thought to be extremely chaotic. People did social distancing, but even within their own families, like there was no public health system, there was no message from a government, this is what you should do. And it was thought to be just incredible chaos and millions of lives lost as well, maybe because of the chaos, or the chaos is because of the million lives lost, or both. And what we've found over time, when you look at other infectious outbreaks in modern times, for example, the Spanish flu epidemic in the late, in like 1918 or so, right there, like what, 50 million people died. It's just, massive, like incomprehensible loss of life, levels, magnitudes of loss of life. But the the U.S. government at the time made a conscious decision not to talk about the pandemic. That was President Wilson. And I'm not a historian, but from my reading of the history, there was a decision we don't talk about it. And if we talk about it, we say good things about it. And with that, and newspapers apparently followed that lead as well. And what that was thought to do was actually engender a lot more chaos and disarray. And in cities where the localities were much more upfront, it was felt to actually help promote, social harmony and, productive behaviors. And then when we fast forward to things like SARS in the early 2000s, we see there, now we start seeing actual research studies looking at the mental health consequences of that epidemic. And what you found is, particularly when you look at healthcare workers, there were definitely higher rates of post-traumatic stress disorder and major depression in healthcare workers in particular. And the things that were protective there were, in fact, feeling supported by their supervisor and having information, right? So that's like a very, very kind of consistent theme through all this. Support and information are, not very technical interventions, but they go a long way, and they were protective, reduce the risk of PTSD and major depression in those healthcare workers. And the recent studies out of China looking at COVID-19 in healthcare workers found that this very same thing. Firstly, the people that were at greatest risk were nurses and doctors on the front line. That's not a surprise. And there too, same exact finding from, information and support went a long way. So that's like the basic takeaway from infectious outbreaks. So to think really broadly about general interventions that help people to manage well psychologically from disasters in general, and maybe specifically from infectious outbreaks. So I have about 6 or 7 of them. The first one is actually a set of broad principles, and within it, there are 5 principles. A bunch of experts sat down about 10 years ago and said, we're never going to really be able to do like a double-blind placebo-controlled study of how to help someone who's recently traumatized. It's too ethically problematic. It's too logistically problematic. But let's get the smartest minds together, and what can we say? And they came up with, it's basically something called psychological first aid, but it's actually been boiled down. This is an even more boiled down version of psychological first aid, which usually consists of about 10 or 12. These are 5 broad principles. I always tell people, if you don't remember anything at all from what I say, if you can remember just one thing, it would be these 5 principles. And maybe they don't seem very, complicated, but and they're probably easier said than done. But the 5 are: 1, promote a sense of safety; 2, promote calming; 3, promote a sense of empowerment; 4, promote connectedness; and 5, promote hope. Those are the 5 broad principles, and they're strategies, right? They don't tell you how to do all that, right? But they at least are a little bit of a guiding principle. So those are the broad principles, and then that's like sort of point 1. Point 2, I've already said, is information. People need information. These days we have a little bit of a challenge because there can be too much information to sort out. So in the modern era, we have a different problem than they had back in the Black Plagues. They didn't have enough. We might actually have too much. But we do need people to have trusted, reliable sources of information. And I know from my own perspective at Mount Sinai that the health system has been very good about daily messaging with things that we need to know. And it's been very helpful, I think. Point 3 is to actually allow for anxiety. One of the worst forms of anxiety is anxiety about anxiety, being scared to be scared. And these are frightening times. And as I said earlier, actually some anxiety actually is functional and probably necessary, right? For example, sheltering in place and being home so much while it's safe and secure. Also, to do that, because it's actually uncomfortable for people, requires some fear, right? You have to have fear to do that. And so we wanted to some degree normalize anxiety and make sure that, although do our best to make sure then again that people are on the healthy side of anxiety, not the unhealthy side, if possible. The other thing, 4th point is I like to tell people who are worrying a lot, right, is to let those whose job it is to worry do the worrying, right? We have government officials, all right, who signed on for this, or if they didn't sign on for it, now they have, and it's their job to be doing the worrying about the things that we need to do, and hopefully, trust them and follow them. And then, so that relates to my fifth point in terms of how to intervene, and that is focusing on what one can control, right? So, right, worrying about things that one can't control, we all probably tend to do it to varying degrees, but it is very draining and a real energy sink. And imagine all or many of you are familiar with the Serenity Prayer, which I think maybe originally derived from Buddhism, I think. But wherever it is, I often cite that, although I often cite a different translation of it, which is the following from Mickey Rivers, who played center field for the 1978 New York Yankees, the World Series champs. He was a very outspoken person, and there are all sorts of quotes you can look up. But this is one quote that I copied down from him. Ain't no sense worrying about things you got control over, cause if you got control over them, ain't no sense worrying. And ain't no sense worrying about the things you don't got control over, cause if you don't got control over them, ain't no sense worrying. Right, that's the Serenity Prayer translated by Mickey Rivers, and it's actually all of cognitive behavioral therapy in 2 sentences. And I talk about that with people a lot. The sixth point about intervening is social support. Right, this is one of the best known ways to mitigate the adverse effects of trauma on people, and social support. Right, these days may seem challenging. Right, we talk about social distancing. All right, but I think what we try to rephrase that is physical distancing, not social distancing. So here, I have a quote actually from a Rabbi Yosef Kanevsky, quote, and the very last thing we need right now is a mindset of mutual distancing. We actually need to be thinking in the exact opposite way. Every hand that we don't shake must become a phone call that we place. Every embrace that we avoid must become a verbal expression of warmth and concern. Every inch and every foot that we physically place between ourselves and another must become a thought as to how we might be of help to that other should the need arise. And again, this is not like from a psychiatry textbook. This is from a rabbi. There actually are research papers that support this. But social support, whether in the form of, from the chaplaincy, from a neighbor, from a physician, from family, is abundant and free and natural. And of course, the seventh intervention in the long run, if people develop psychiatric issues, would be, of course, psychiatric treatment. But of course, to some degree, we're having this talk today, I think, in order to try to avoid all that. My last section is just to relate this all to health professionals. I think, having said all the things that would be good to do in broad strokes, there are a number of issues that specific to health professionals, some of which are going to get in the way of efforts, I think, or one needs to be mindful of if one is going to do disaster chaplaincy with frontline providers, healthcare professionals right now. So one is, so there are 8 different items. One is their role, what's called role clarity. But basically, how do they understand what their role was in this event and what they were doing? Now, for a doctor, that's pretty clear. But for support staff who have been thrown in, and we've had many staff here that have been so-called redeployed, who previously were like a program coordinator in the medical school, now are being thrown into doing supply management or something, right? And they're thrown right into the middle of the response. And this is not what their natural training was for. This is not what they signed on for. So we definitely have to really be thinking about the sort of non-traditional sort of healthcare responders in all this. Even folks like housekeeping, for example, who are now doing their work in settings that's unfortunately saturated with death or the threat of death, and overpopulation of patients, etc. For them, having role definition is very important, and many of them may not feel like they did. Number 2, this gets back to something we already said earlier: the quality of supervision, the compassion of supervisors that healthcare providers have are very important, and how nimble they are. And I can think of many instances now where sort of supervisors have almost become like army recruiters, like, you're going to go and do this, right? There's a real militaristic quality, at least to what we're seeing here in New York, right? We're talking about being deployed, etc. these are not terms that healthcare professionals, at least outside the military, civilian healthcare professionals are used to. And that is greatly, that's something to be aware of too. Third, now these are some things that are pre-event, is the culture of self-sacrifice that exists in medicine, right? Doctors in particular have a long legacy of feeling like they have to, it's important to, you can never, in some sense this is true, one can never do too much for a patient, but that can lead to overdoing it for oneself. And that relates to a fourth item, which is the kind of the culture of self-neglect in medicine, particularly again, I think amongst doctors, right? The, overlooking one's own needs, physical, spiritual, mental, emotional, because that's what you do. That's what you that's what you feel like is important for you to make your fullest contribution, is to overlook yourself. So I think that is a big challenge now. It was a challenge before COVID-19. It's certainly going to be a challenge now. And related to that, the fifth point is that there has been a lot more studies about burnout in physicians in recent years, much more attention to that, and that the levels of burnout in different groups. One of the highest groups that when you do studies of burnout actually are emergency medicine doctors, right? Some of the very folks who are on the front lines right now. So some of them are coming into this potentially with some burnout. The sort of caveat to that is that there has been an emerging attention along with those studies about burnout to wellness. So there is more and more of an attempt to instill a wellness culture in medicine, but it really has just been getting off the ground. I'd say a lot of places have chief wellness officers. We now have that. One of my friends is the chief wellness officer for Mount Sinai, but that's still kind of early. And so that sets some of the background for some of this. A few last points is guilt. It's interesting, the role of guilt, because you talk with lots of people and they feel guilty that they are, let's say, not on the front lines, or they're not doing this, or they're not doing that. I think if you actually speak to people who are on the front lines, they actually feel guilt because they don't feel like they've done enough, right? Thousands of lives lost, and the manner in which they lost, with many patients particularly dying alone in the hospital without their loved ones there, right? Medicine is not being practiced in the usual way, and is much more of a loss of life than any doctor has ever been used to, certainly civilian doctors. And so there's going to be enormous amount of guilt to go around, even for frontline healthcare providers. And related to that may also be survivor's guilt, right? Particularly if fellow healthcare providers died, and unfortunately we've had that too, or have taken very sick and have been disabled by the virus. There's going to be survivor's guilt in healthcare professionals. Last 2 points is the idea of moral injury, which was a concept I always knew about it, but I never really knew the phrase for it. But now I've learned it recently. Moral injury, right? Being forced to do things that are against your morals under the situation, right? So the idea of potentially having to ration ventilators, for example. I don't know how much of that has gone on in the trenches, but that's been the big concern. Who gets a ventilator, who doesn't? Or the idea that loved ones are not allowed to be at the bedside when somebody is dying, right? That causes moral injury to the healthcare provider, and that's going to be something we have to contend with. And then finally, something again that is pre-COVID-19, and I'm not sure how many of you work in healthcare settings and do healthcare chaplaincy, but medicine on the whole is very non-spiritual, at least the way it's practiced these days, right? There's much more of an emphasis on science and evidence, and a lot less of an emphasis on belief and conviction. And sometimes one I find has to be a little even sheepish about mentioning spirituality, let alone religion, in medical context. So I think that that's another potential challenge. On the other hand, I'm sure you all know that this. I keep thinking of this phrase that there are no atheists in foxholes, and so whether medicine has a spiritual bent or not coming into all this, maybe that will be changing. And that is my talk. Thank you very much.
Thank you very much, Craig, for this. And I think that the most common question I've gotten so far is, can we get all of this? And so the answer is Yes, we'll make sure all this is available afterwards as part of the recording and everything that we send out. Now, I've had one minor achievement since Craig was talking, and that is, Tim, I figured out why I just like totally stumbled over your title. So allow me to reintroduce you. Tim Serban is Regional Spiritual Health Officer for Oregon and Providence St. Joseph Health. I just wrote it down kind of funky. So anyway, I will turn it over to you.
Great, thank you, Michael, and Craig. Thank you as well for the framing up of the situation as we experience it right now. I would start by just addressing the fact that not only with my role with Providence as a spiritual health officer and most recently disaster response, who knew that this would unfold as it unfolded, I also serve as the national lead for disaster spiritual care with the American Red Cross. And so in the experience that we have of supporting those providing disaster spiritual care across the continuum since 9/11, many have kind of come and said, how are we to do this? And I would just start with, there are a number of disaster spiritual care wisdom sayings that are out there, and you'll probably be asking for it, and yes, we can get it to you. But one of the ones that I try to start with is that no one who witnesses a disaster is untouched by it. When we hear, I've often found myself watching the Johns Hopkins numbers, the grid, and seeing how those unfold and all, and recognizing how daunting and heart-wrenching it feels to see the numbers double and grow in such a way. But first, I just want to point out, there are never just only numbers. There are never just this number, this trend, or this curve. I'm coming from a very deep place at this moment in time. Just last night, I got a call from a family member who we've had in the hospital, who happens to be a fire captain and has been in ICU with COVID-19. And about 4 o'clock this morning, he died as a result of his this entire horrible journey. And so, to our family, I just want to say that this is real, and to everyone who's out there, the sense of impact that it has is touching all of us. It's so different than any other disaster, where you go from a safe place to an unsafe place to serve and provide support. And what needs to happen is, or what happens in this situation, is that not only is it regional, not only is it, we've had systems that expand across the country in order to help other states support those in need, and other countries often help those countries in need. And when it happens globally and recognizing this, it is expansive and vast. Craig, you mentioned resilience, and I just want to affirm the pieces of how important it is for us to ensure that we engage in the resilience, in the sense of recognizing that if we hang on long enough and we have the shovel that we have in our hands, we can get through the mountain that's in front of us. The counseling tips and tools and the resources that we provide, I simply invite people to remember them, that they're just giving us bigger tools to get through it more efficiently and more effectively. Another spiritual care wisdom saying that I often refer to is, draw the lines before you leap, or you'll end up in an overwhelming sea of unmet need. Which means simply, before you jump into something, you got to test and know the water, orient yourself. Information, you mentioned information. I have a great story after Katrina. In Red Cross, the first team that goes in are the IT disaster response people, and they provide what I call laptop therapy, because the laptop therapy is when you're cut off from the rest of the world, they reestablish that connection to the real world. And just knowing what's happening out there it relieves just a tremendous amount of stress. It relieves a sense of just, people will say, if there's an air disaster, you escort families to a family assistance center, but you don't put them in front of televisions. We have often found that actually having a room where televisions are there, they could actually go when they feel safe to do that and not. But today, with today's world, the information technology, everything is happening real time. When I look at this situation, it draws me back to a lot of parallels within disaster work. The disaster cycle talks about 3 phases. There's the preparedness phase, there's the response phase, and the recovery phase. And I'm often engaged, and our teams are often engaged in the response phase. And we know pretty quickly over the weeks that unfold after a major disaster, when we start hearing conversations about recovery is starting, that is a turning point. That is a marker that we identify where we are from the short-term response to the long-term recovery, which takes 2 to 3 years. I would just say that we are still in the response phase. If we are still sheltered in place, we are still well into the response phase. The recovery may not still be there. And as we talk about helping our colleagues, it's important to be thinking about where they are as well. We've created a model and a resource in our health system. I often, the other thing that I look at not only at the response, the recovery cycle, is the emotional life cycle of a disaster. When you think about the emotional life cycle of a disaster, it begins with the impact of the event. Then it moves into what we call the heroic phase, where folks just jump in and they want to help. They want to do something. The next phase after that is the honeymoon phase, where all the community partners are coming together. Everyone is making masks and making shields and doing everything and really collaborating and just doing a lot of work to help. Unfortunately, the next part of that is the disillusionment phase, when we start realizing our kids are still in the house. School is not going to be open, and the disillusionment part of this is hard and this is real. And the fact that while we hear flattening of curves and we hear changes and all, the reality of it, of living it, is so different than thinking about it and trying to see about it from something separated from ourselves. Once I orient myself to those pieces, I also think about the wisdom saying that says, simply draw the lines before you leap, or you'll end up in an overwhelming sea of unmet need. Before we go in, we need to have strong anchors. And by that, it's simply, what are the things that you draw on to hold your source of strength, help you not get overwhelmed. This often feels, I've heard it described as a beach ball that you're holding under the water. And we're actually holding under the water, waiting for this wave to happen and finish. And we're wondering, with a sense of anxiety and restlessness about, is it going to pop back up? I also just go back to Maslow's hierarchy of needs. And Craig, you mentioned it as well, is that we first need safety. Safety is first essential, then shelter and food and hydration. So when we think about it, I ask our caregivers, do you feel safe? And with the shortages of PPE and with all the things that keep the uncertainties that come up and down, and the changing directions about what's assigned, what are we using today, what is the parameters, what's the algorithm that we need to use today, that creates a lot of distress among providers and caregivers who are used to very clear black and white, parameters of how we operate, algorithms and strategies. So I would say that it's important to be thinking about the basics, really going back. It seems simple, but the basics are so important. How do we have shelter, safety, food, hydration? The next part of Maslow's hierarchy of needs is community, and everyone in spiritual care, and knowing that this is about coming alongside people where they are, irregardless of their tradition, and honoring their story and helping them find meaning in the midst of this, irregardless of their tradition. So, but before they can even go to those places, they need to know they're safe. They need to know that the PPE they're using is trusted. The resources they have are going to be reliable, and that we have some sense of timing about when is this going to change? What's the next phase? When are we in recovery? And how do we know that? Clear markers with the information that we're sharing. I would ask Michael, if you could drop in the slide that we have. This is something that we just created within our system, that in partnering disaster telehealth, we call it we call it actually telespiritual health. We thought the best thing to do is for our entire health system is to create this stress meter that just says, how are you doing in your stress level, from this little happy blue face all the way up to the very distressed 10. And people are simply clicking it. And when they click it, they're identifying where they are, and it gives us an early look. It really just, the best part of it has been able to help us see which states in our Western United States are the most stressed at this time. What are they feeling and how are they experiencing it? Rather than just having telespiritual health or telechaplaincy, as we call it telespiritual health. rather than just having it, it has to be partnered with the behavioral health support and component to ensure that the entire continuum of care is available to caregivers. We call all of our associates, all of our employees, caregivers in Providence. And I would ask you to go to the next slide. Behind this stress meter, the thing that people don't see, but what pops up makes that available is this continuum of resources. And I'll just simply highlight Credible Mind is a resource that was created by Stanford and Harvard to use artificial intelligence to identify what is your learning ability, what do you like to do you like to learn from, do you like Headspace as a resource. These are apps, simple things that you can do to help connect yourself with your own well-being. So those are, when a person identifies themselves as having mild stress, the option of Credible Mind comes up. And Silver Cloud is a cognitive behavioral therapy that's self-paced. It's something that is used, it came out of Ireland. So that is another self-paced resource that we've kind of pulled together with our digital innovation team. The next level up is our telebehavioral health, or telebehaviorists. So we have psychologists and counselors who are live available to provide support directly with caregivers. And our telespiritual health, which then telespiritual health is available from 0 to 7 on the scale of stress. Once it gets to 8, 9, and 10, then it increases the in-person behavioral health support all the way up to the crisis line, the suicide prevention resource. And so we're able to tell where people are, how many people are visiting, how many people are clicking, where they're clicking, and where they're identifying. As Craig, you mentioned as well, people do tend to ground themselves in their tradition and in a sense of spiritual connectedness. And I would say that what we have found, that of those rating themselves from mild all the way to moderate stress, they have been saying and indicating to us that the number one thing that they're clicking on is telespiritual health. Just to identify and connect on it. They are moving to the other places. Once it gets higher, we have a small number, as you mentioned as well, a small number of people who are actually connecting and reaching out to the crisis line for support. But of the 7,000 plus caregivers that have accessed it, we make it available to not only our caregivers, but to our families of the caregivers as well. All that said is that we've created this resource. We've had it up and running for about 2 weeks. And we have had, again, probably anywhere between 1,500 to 7,000 visits to the site. The pull through is still very flat. It's not folks aren't actually engaging as often. And I think that's part of the telling piece there is really about the fact that it is early. I believe it's still early, and people are, in chaplaincy and spiritual care are often used to coming alongside folks and not waiting for them to come to us. We're not putting a chaplain in a room and saying, go see them when you need to see them. We're coming up to them, looking at their eyes and saying, hey, do you need to touch base? And hey, do you need a check-in? And so that's where our caregivers are saying, yes, you almost tap on the surface. At the same time, when we're in active response and active crisis mode, I will just share a moment after Hurricane Katrina, we partnered chaplains with the disaster mortuary teams. And as they went in to do the recovery, this very difficult, very intense recovery work, the important piece that the leader of that program said, don't disengage or don't tap on the surface of our people and demobilize them, because there's only 4 to do this work. And if you get too deep and unravel them, then we'll only have 3 doing the work. So there's an element right now that I would say that while people are in the survival crisis mode, we need to help come around them and help keep them moving forward, almost wrapping them what I call with spiritual duct tape, holding them tighter to say, let's get through this before you disengage and before you talk about all that's happening. We invite you to bookmark those moments that are most telling. This moment for this ICU team where my relative was there, I would say probably to them, hey, you may not be able to process what just happened here, watching this family and the fire crew outside the hospital, raising their appreciation, but place a bookmark in that spot so that when you disengage and when you get to a safe place, you can come back and unpack these moments of grief, these moments of loss, so you don't forget it. You don't pass it on and push it down and disengage it from it. So that's been our journey, our experience, and I welcome the questions, the conversations that folks might have as we continue to learn from how we might both engage groups of people as well as proactively reach out to check the eyes of our team and colleagues. Michael?
Well, thank you very much, Tim. And I knew one of the questions that we would get is, it, can these metrics or tools be shared? I'm assuming it's not proprietary, that folks can adapt them in their.
Yeah, the FACES is a Wong-Baker scale. That's pretty much the pain scale that is out there, and so that is easily adapted. And we just simply again had an IT expert figure out. I think the beauty was keeping it simple. There's just so much information out there, and so many people want to get their information on the website that it just becomes overwhelming. The only thing they see when caregivers click onto that is they just see the stress meter, and it's like, keep it super simple, and they can then choose. They can scan through the options from telebehavioral health all the way to telespiritual care, and we will set up. Ours are telespiritual health. We will set up appointments to meet with them and provide ongoing engagement.
Sure. Do you, maybe, and this is as much a question for myself as from the audience, but those specific services that were mentioned all along, is that something that you all maintain some sort of access to through your organization, or do you sort of direct people to them and they go and do it themselves?
We have what we call a digital innovation group that spends time researching these organizations and doing the due diligence to ensure that they're a credible organization, that their resources are something that we can be reliable. For example, we have a caregiver assistance program, or EAP, but our caregivers have found that getting an appointment may take more than the time that they need. And so by setting up and standing up this COVID-related telebehavioral health resource, we can get them into an appointment same day or the next day rather than days ahead. So yeah, we try to maintain and ensure that all of those that are represented are things that are probably out there and available, but we spend a lot of time making sure that they're going to be able to handle the 215,000 caregivers that we've got.
Yeah. And to the person that asked that question, I would just say that this is a great template, but of course you can sort of modify it for your own. It just requires, I think, the vetting and the time put into making sure that this is a decent resource. I'm sure that plenty of people here have already gotten emails that are selling things or trying to get you to sign up for things or whatever. Anytime there's a disaster, someone swoops in and sees an opportunity. So the time invested in vetting those resources is certainly very much worthwhile. Now, of course, the questions were coming in as both of you were talking, so we're going to jump back and forth a little bit between kind of the themes here. This is a great question. This person says, I'm noticing two major lines of dialogue affecting medical caregivers in the hospital context. So on the one hand, the language of heroes work here, while at the same time, there is talk about medical staffing cuts. So what impact do these two contrasting realities have on providers on the ground? Craig, I don't know if you've seen any of this, maybe Tim?
Yeah, I mean, clearly there are mixed messages. I think, I mean, just to speak to the being a hero part, being a hero is an enormous burden. I don't think most people sign up to be heroes, and so it's actually, I mean, it certainly can feel good, but it creates an enormous amount of pressure. And so I wouldn't contrast the being the hero part as all positive and the cutbacks as all negative. Obviously, the cutbacks are negative. But I think there are a lot of mixed emotions going on out there, including working as a hero. And I think that speaks to the incredible pressure that healthcare providers feel under normal circumstances, some of it internally driven. And then when you have this enormous social attention, it's even more pressure. And when you have all these people in front of you that need care, it does as well. So yeah, so those are I think a lot more nuanced than it might appear on the surface. So.
Yeah.
Yeah, we've had similar reactions as well, where folks are saying, "Gosh, I don't feel like doesn't feel good." If ICUs and attentions to hospitals tend to get a lot of focus when nursing centers and nursing homes and others are just struggling in so many different ways, I'm concerned that that is the hidden tragedy within the tragedy, is these places that are just being held by just a thin thread. Are facing such burden, and at the same time, as chaplains all know, they may be called any number of things. People will associate, hey, preacher, pastor, sister, father, and they recognize you can spend your life trying to correct the language, or you recognize people are associating their desire or need to have some sense of celebration, some sense of honoring, and whatever it happens, it becomes a parade of emergency vehicles in front of your hospital that are blowing their sirens, is their way of just simply saying, we thank you. And if there's an opportunity to just, as the light is shining on your area, to be able to redirect it towards those areas and say, remember, our hospices and our elder places, our homes of centers, of nursing centers also need your attention and your care.
Craig, one of the things that you mentioned was this culture of self-sacrifice. You mentioned the mindset, which of course I'm grateful for, that there's never enough I can do for a patient. There's never too much, but also a sense of self-care going down the list of what a medical healthcare provider is going to do. And I know just from the conversations that I'm plugged into that this is something that chaplains talk about all the time, chaplain self-care, especially depending on the context where you're working, where you may be introduced to some pretty heavy material on a regular basis. But at least from what I can tell, it's a much more common, open conversation that chaplains will lift up their own need for self-care, will take the time to step back and do a little bit of that work. There are some similarities here, but clearly there's a little bit of a cultural difference here. Tim, maybe you can speak to how can chaplains support healthcare providers, being able to step away and take care of themselves. I always think of the phrase that you can't pour from an empty cup, and I know that's trite, but it's also true. How can chaplains be effective in this way?
Well, I think we're asking that question daily, and I think it's a common question. When I hear it in multiple places and multiple times, there's kind of a mind meld of conversations that are happening. Historically, we would just come alongside caregivers and look at them and say, hey, how's it going? Or talk to their leader and check in and say, how are things going with your team? We found that just even yesterday, we were talking about there are two groups within our organization. One is the group of those who are on the front lines doing the work, and they are tired and they are drained. There's a whole other group of folks that are sheltered at home because of volumes have dropped and their desire or their work is not there. And so they're home. And so for them, they have a great sense of anxiety, or that uncertainty and anxiety. We've been talking as well about how do we proactively reach out to our caregivers, that either those that are at home, those that are in need, and in some way talking to managers and others and saying, how can we proactively not just wait for them to call us, but just go and do a check-in and have somebody say, hey, these are the resources that are out there. Your leader thought that it might be a good idea to check in. And I think the same with our chaplains as well, is we were doing a regular daily check-in with the leaders, and we heard from a colleague in the VA saying that they are treating this really as a mass casualty psychological event, I think is the term they used, where they're turning it in a way that this is a wartime response for the VA. And so the reality is they simply gave us 5 simple tips. One was, no matter what's happening on the front line facing teams, huddle at least once at the beginning of the shift and the end of the shift and make sure the leader's there. The second thing was, no single person owns life or death making the patient decisions, so that know the algorithm that's being used today, even though the algorithm might change, make sure that no one physician or one provider is actually the one making a decision. We're not at a triage place in most of our places around the country. However, we want to make sure that everyone is being supported. The third was just take breaks, make sure the simple things about the 10-minute breaks, have on-site psychological first aid, on-site check-in with folks to be able to be there in the midst of the surge, But as soon as the surge is starting to taper off, that's when we need to have robust on-site support counselors, in the sense to be able to debrief and check in. And we do a regular check-in with our chaplains as well, once a week, just to give them information, and to also, we actually had a moment last Friday where we had one of our music thanatologists who provides prescriptive music for those who are in distress and patient care. We have about 6 to 10 of them around our ministries, and we provided a kind of a musical surrounding of support for all of them during that day, just to give them an hour of reflective time.
Right.
Yeah, and if I could speak to that also, Michael, I mean, usually what I say to about mental health, specifically talking to mental health professionals that do disaster work, is I always say to them, when you go in, first, you're a person. Second, you're a doctor or a social worker. And then third, you're a mental health professional. And I wonder if the same analog might apply to the chaplaincy. First, in terms of making that connection and going where people are at. First, you're a person. Second, maybe you're a chaplain. And third, maybe you're a pastor or a rabbi or a priest, right? And if you think in those terms, it might be a little bit easier to engage and not feel like you have to go to the third tier right away.
Yeah, right.
Yeah,
There is,
nobody uses their highest skills in the midst of a disaster. It's handing water. It is the basics, going back to just the simple basics.
yeah. There is a great question here, and I love this question. And it has come across my mind too, because I've seen a couple of things, on the internet of someone makes a parody video of a song or something related to the coronavirus, and you wonder, this is levity, but should I be laughing at this? This is a very serious event. So this question came in that said, like many places, our temperatures are taken as we enter the hospital. Today, the person doing that was dressed as a dinosaur. What are some appropriate ways to incorporate humor or blow off steam in the middle of this that doesn't deny the gravity of the situation? What are you all seeing, or what's effective for you?
Well, that's a tough question, right? I mean, I remember after 9/11, right? There was literally this question that was being asked, like, when is it okay to laugh again? I remember it was when one could Stand Night Live go back on the air, for example, or um, I don't know the answer to the question. Actually, I think if you ask the question, then then you're in the right frame of mind. Whatever answer you come up with is up to you. But if you're at least asking the question, then you're probably doing a good job of balancing the two.
Yeah, and I would say that appropriate humor is reasonable, but slapstick kind of just there's a timing and a place for everything. I just remember years ago when I worked in a place where it was Halloween, and we had the Grim Reaper show up at a code, and they were dressed up, and it was like the last time we had caregivers dress up in a hospital.
Yeah.
But there's so appropriate sense. I mean, we've got to be able to laugh. We've got to be able to ease people's anxiety. And I think that I mean, I just remember after 9/11, around October 11th, I was in New York City as part of the response team. And it was the first day, I think, just before like October 11th, that I started hearing horns honk again, and the F word being just thrown about like crazy. It was like, they're back, and then someone yelled out, "We're back!" And it was this whole sense of just release. That again, there's a time when we've got to let the ball that we're holding down, the beach ball under the water, just to let it out and to let it come forth. And it does. There's a powerful. I think it's an Iranian cartoonist who has he has done some incredible cartoons of the palpable dichotomy of the coronavirus. I'm happy to share that, Michael, as well. But there is some appropriate ways to create both the reality and the sense of folks are doing an incredible work above and beyond the call of duty, and should be honored in a way that honors them, maybe not as heroes, but as really folks who have come together to really do good work.
Yeah. I think we've got time for one more question here, so I'll lay this out, and it has to do with appropriateness as well. This person asked, what are the ethics behind the spiritual care duct tape? That's a wonderful image and metaphor, and I think I really understand how this could be a difficult question. What, when you're just trying to do one thing, what are the ethics behind that?
Oh, I think that again, it is a matter of knowing when to tap into the deeper places. If a person is many chaplains are not in the field. Many chaplains are, in a sense, within the confines of a facility or the hospital, unless those who are working with firefighters and with police who are out there in the trenches. When you go out in the trenches, there's a protocol and a process that needs to happen, and to get in the way of that, if you're in a SWAT team response as a chaplain, you're not jumping in in front of the line or in the hot zone or anything else. So there's elements of where people need to work, and to get in the middle of that without knowing where to be. Chaplains who work in critical care areas and all know where to stand and where to move when there's a code happening, and they're not really tapping into the engagement of, so how are you feeling at this time, or how's it going, or what's going on. So it's a matter of understanding the timing and the process. In a disaster, all of that gets protracted out, and it makes it's just a whole lot longer. I would say we normally have the ability to follow a patient from the ER all the way up to discharge through every element, but the first 2 weeks of a disaster, I often say, are taking the patient from the front doors to the ER. The next 2 weeks are taking them from the ER to the OR. And the next 2 weeks, it just is so much protracted, and that's what it feels. It's like going from the hospital to hospice. What you're doing in hospice is not as rapid paced as you would do in the hospital. You've got to slow yourself way down and give yourself some patience to not just try to get to the heart of what they need to say, because you can unravel them. And if they start unpacking what's happening there in the field, you've now have somebody in tears. And it's that whole sense of how do you help them stay together and focus on the mission until we get to disengage. We're not denying it, but we're knowing the appropriate timing of it. That is professional chaplaincy.
Well, thank you. Thank you so much. I want to be wary of the time here and respectful of everyone's time. Thank you both so much for this. We're always grateful to all of our webinar guests, of course, for their time. But this is a unique thing for all of us, and maybe most unique in that our panelists are going through it just like the rest of us are, and sometimes experiencing it in more intense ways. And so to take time away from that and to give us your time and your energy, I'm so grateful for that. So thank you both for being here. For anyone who may have come late, no problem. These are all recorded, and so everyone who was registered gets an email that has the full recording. The materials that we discussed here, you'll get those as well, so don't worry. Everything that we talked about, you will get that as well. I just want to make a note of a couple of other events we have coming up. Tomorrow, we have a webinar on how to provide spiritual care within long-term care settings. This gets to a little bit to what Tim was just saying of where things move at a little bit slower pace. What is it like to do spiritual care there in the midst of a pandemic? So we're going to be joined there by Sarah Posh Orlo, who's a chaplain at Hebrew Senior Life in Boston, Janet Troutman Miller, who is a chaplain at St. John's on the Lake in Milwaukee, and Judith Holmes Jensen, who also does elder care work in the Milwaukee area. We're co-sponsoring that with Transforming Chaplaincy, so we're very happy to have that event tomorrow at 4 o'clock. On Tuesday, we continue the Chaplaincy Innovation Lab series of Caring for the Caregiver town halls at noon. Everyone is welcome, and it's just a place where we hear from an expert for a couple of minutes, and then really it's just sort of an open conversation for chaplains to see what they're experiencing, what their advice is for each other. It's a wonderful event. And then finally, I'll mention next Thursday, we're also going to do a webinar on rituals and caring for staff that gets to a lot of the material that we were talking about here today. So please do join us for that. These are all mentioned on the website, chaplaincyinnovationlab.org/webinars. Everything is free, everything is recorded. We want these materials to be available for everyone as they need them. Thank you all both once again. We really appreciate your time, and I look forward to staying in touch. Thank you all. Bye-bye.
Thank you.
Thank you.